Diabetic neuropathy is a little bit more involved than the other two microvascular complications, nephropathy and retinopathy. So it's going to take a little bit more time to go through, but it's definitely important to understand. So the damage that is done to the nerves involves mostly these C fibers and A fibers. Now, you can go back to the video on pain and nociception. I think there's a good breakdown of the difference between these two things, but I'm not going to go through it for this video. The idea is that it's affecting these two kind of ways that the synapse or the impulses move along the nervous system, right? And so it ends up causing this peripheral nerve degeneration. There is a demyelinization of the Schwann cells, which is going to slow nerve conduction significantly. I don't know if you remember, I think we were talking in one of the other videos, the Schwann cells are these glial cells that are in the peripheral nervous system, and they help actually make up or form the myelin sheath that's around those nerve fibers. Myelinated axons conduct much faster. The impulses travel much faster than unmyelinated. Myelin actually provides a little bit of insulation to the nerve itself as well. I did put in this little kind of thing here because these oligodendrocytes were coming up here and there when I was reading through, and I thought, okay, let's just make sure we know the difference between the two things. So they both are responsible for providing or forming or shaping the myelin sheath. They just do it a little differently and in different areas. So I just said earlier that the Schwann cell deals with the peripheral nervous system. If we look over here, right here, right? The oligodendrocytes, they provide or generate kind of those myelin protections or what have you, but they do it in the central nervous system. This kind of won't matter to you. They both insulate the nerve cell. One does it in the CNS, the other in the PNS. Both are going to make that impulses move much faster. So if you look here, there's kind of a little breakdown, a little picture for you. So these are like the star-shaped kind of ones, but they're essentially doing the same thing. If you look, it's wrapped around the axon, causing it to speed up. It's just shaped differently, and it's wrapped around different. It's wrapped around more than one. Whereas you have with the Schwann cells, you have this peripheral nervous system. You've got them all wrapped around the same axon, and they just do it differently. That is probably way more complicated than I've just explained it. And I don't care, because it's really not important for what we're talking about right now. One day I might make a video that goes into detail a little bit more on this, but for now I think that's probably good enough. So what happens in diabetic peripheral neuropathy? Here's kind of a little picture of what a healthy nerve and blood vessel kind of conglomeration looks like. So if you look here, you've got, let me just make this a little bit bigger so we can look at it. You've got obviously this. Here's your, this here is your blood vessel. Here's like the myelinated nerve fiber, an unmyelinated nerve fiber, and these are running through the nerve, sending kind of signals, right? If you look over here at this is a damaged nerve. You can see like the blood flow, there's occlusion there. So you can just kind of see there's damage to the unmyelinated nerve fiber, right? Those A fibers, and there's damage to the myelinated ones, the C fibers. So there are kind of two categories of diabetic nephropathy, I would say. You have peripheral or somatic nephropathy or autonomic neuropathy, has a lot to do with, if you remember this little breakdown of what the nervous system looks like from anatomy, You've got your central nervous system over here, but this is the side we're really talking about now. We've got the peripheral nervous system, which includes your motor neurons and your sensory neurons. So you've got your afferent nerves that are sending signals to your brain to tell you what you're sensing, and your efferent nerves that are sending signals to your muscles and so that you can do things, right? You've got this somatic nervous system, a part of that controls your voluntary movements, and the autonomic, which controls your involuntary. And then inside of that, or underneath that, you have your sympathetic autonomic nervous system and your parasympathetic, and we've talked about these ad nauseum, so I'm not going to go into them. And so really the difference between neuropathy in as it's classified is just if you look at what the peripheral nervous system is and what it does, you're going to see what's going to happen if you have neuropathy in that system. It's usually very slow in onset, and it shows this, it's called a stocking and glove distribution in the distal extremities. Basically, I think some of the slides said distal symmetric polyneuropathy, which is it's just another fancy way of saying that stocking and glove pattern. What happens is you have these sensory symptoms like tingling and numbness and maybe hypersensitivity or what have you. And what happens is it starts in the tips of your toes or the tips of your fingers, sometimes both at the same time, and then it slowly moves its way up. And so a lot of times people will have like neuropathy in their toes and just not really care, not really think anything about it, but it's going to continue to move unless we get a handle on that glycemic control, right? And so these kinds of symptoms can be are often actually sensory. You've got that numb feeling. Sometimes you can have this painless you have painless injury, meaning you have an injury and you don't feel it, which sounds good, but it's actually very bad. And you can have this hypersensitivity to light touch. If you've ever had neuropathic pain, it is excruciating. I actually have had neuropathic pain. It is excruciating. There's really no other word to describe it. This kind of burning electric shock-like feeling. It's absolutely terrible. And so when you see peripheral somatic, I just want you to think about like sensing, touching, pain receptors and things like that, because the autonomic neuropathy is really dealing with, obviously, with your involuntary bodily functions. So things like your heart pumping, your peristalsis in your GI system, and so that's where you get symptoms. You will have cardiovascular, GI, genital urinary responses and symptoms. So sometimes you'll have a generalized autonomic neuropathy, so you're just dizzy and you have syncope, but oftentimes you have symptoms that are related to the actual site of the nerve damage, and that site can be most often it's in one of these three areas, but it can be anywhere. So GI, you end up with this gastroparesis, which is like a slowing down, right, of your GI system, like inhibiting peristalsis. Of course, that's going to give you a feeling of fullness, nausea, vomiting, and then sometimes diarrhea, which kind of seems counterintuitive, but cardiovascular neuropathy has all the things you think it would. Orthostatic hypotension, near syncope usually when standing from lying down, right? Tachycardia, heart rate variability, dysrhythmias, change in baroreceptor reflexes. Remember what baroreceptor reflexes are, and if not, run and check out the first 2 minutes of the hypertension video that we posted. Exercise intolerance, and then this painless MI is really interesting, and I think that's the lack of sensation now that you have, and you're having an MI and actually don't feel it. And then genital urinary neuropathy, so poor urinary stream, inability to empty bladder. straining to void, sexual and erectile dysfunction. And then there are these kind of like other non-specific ones that are common. So dementia, altered sensory perceptions, like not knowing where you are in space. Sweating is pretty common. And then an inability to regulate temperature. So these ones that I've written down are the more common ones, the ones that A, I've seen show up on tests, B, I've seen show up in patients, and just kind of didn't want to go through too much and go too crazy for you guys. Just kind of think it through when you're looking at some of these things though, because the test isn't going to ask you, straight out, what's a symptom of autonomic neuropathy. It's gonna say something like, the patient has recurrent UTIs, and you're gonna think like, okay, well, where does that fit in? And so you kind of think about things like an inability to empty bladder. What would happen if you have urinary stasis, right? And all that urine is staying in there and it's pooling, and you're at a very high risk for UTIs. So people with that genital urinary neuropathy do have a lot of UTIs. They also have a lot of renal complications, right? The sexual erectile dysfunction is very, very big. It's actually, diabetes is actually the leading physiological cause of erectile dysfunction, like whether you have type 1 or type 2. In terms of physiological, we're not talking about like emotional or mental. So with the urinary retention, they do have this kind of, you'll have patients who have like this genital urinary neuropathy from diabetes, and it seems so weird when you have a patient come in, because you just don't tie those things together. Usually you're thinking kidney or cardiovascular, but the GI/GU stuff I never really think about. But they'll be very, very adept at self-catheterization and doing like massaging on their bladder to try to get rid of some of the urine. So usually management of neuropathy, of course, we're controlling our blood glucose, controlling all of these chronic problems. There are, unfortunately, a whole new set of medications that we use to treat diabetic nerve pain. So, honestly, in general, all of these are just nerve pain. They're medications we use to treat nerve pain in general. We have tricyclics, other types of antidepressants like SSRIs, anticonvulsants like gabapentin, and then often we will use opioids to control the pain. I will just highlight those in the next video. Treatment for neuropathic pain is often a lot of adjunct therapy. So they might use a tricyclic and some gabapentin, and then breakthrough opioids or what have you. Like I said before, neuropathic pain is excruciating. So, sometimes people, they get to the point where it's we just do anything to make the pain stop. Some of these are really good options and they work really, really well. Let's start with the tricyclic. So these are probably, hopefully you already know, they're used to treat depression. It's really funny, most of the time when I see tricyclics prescribed, they are for their off-label uses. I think they're used for neuropathic pain and insomnia more than they are for depression. I think they work better for those things than depression. So what does a tricyclic do? It decreases or inhibits the reuptake of serotonin and norepinephrine in that synaptic cleft, and that means you have more of it left in your system, and that actually will decrease pain transmission. Again, there's a video on nociception and pain and how norepinephrine and serotonin play a role in that you can watch. For now, it's good enough just to know that they're believed to play a role in the transmission of pain through the spinal cord, an inhibitory effect on pain transmission through peripheral and central nervous systems is what we're doing here with these tricyclics. Again, it's an off-label use. Adverse effects. Interestingly enough, tricyclic antidepressants are anticholinergics. Cholinergic is the word we use to describe any system that uses acetylcholine. And the main one that we've studied in nursing school would be your parasympathetic nervous system. And so when we are working against a parasympathetic nervous system response, we are going to get a sympathetic nervous system response. This is how I think about it. And so whenever I see an anticholinergic that I know is working against the parasympathetic nervous system, I know it's going to have a bunch of sympathetic nervous system responses, like it's a fight or flight. So like increased heart rate, urinary retention, dry mouth, peristalsis like constipation and decreased peristalsis, blurred vision. So all of the things that are happening to get your body ready to fight or flight, to shunt your blood to the vital organs, to your brain and your heart, all of those things that are going on in a sympathetic nervous response. Again, you can check that out in a different video. That's what's going to happen when you take an anticholinergic. This one actually is fairly potent. I actually did try this for my neuropathic pain. My heart rate went through the roof and the dry mouth was like almost unbearable. It was really hard to talk. Everyone doesn't have those strong symptoms, but some people do. So if you run into trouble, just remember that it's an anticholinergic, and that should give you 10 or 15 symptoms just off the top of your head. It does cause, or there's a risk of orthostatic hypotension. There's extrapyramidal effects, as there are with many antipsychotics. You know what? I'll talk about them when I talk about mental health, but they're kind of like tardive dyskinesia, almost like Parkinson's, like shaking and stuff like that. They do cause lethargy and sedation. In fact, they are one of the other off-label uses other than neuropathic pain is insomnia. There is a high risk of suicidal thoughts at the very beginning, so it's a transient risk. So when you put someone on tricyclics, especially, you would probably try not to put someone who had a severe history of suicidal ideation, but especially if they did, you'd be watching them very carefully for the first 3 to 6 weeks. It does, like almost every other antidepressant, cause weight gain and have sexual side effects. So those are just kind of like the main things. If you come across, it's never ever shown up on a test for me, but SSRIs and tricyclics and a lot of antipsychotics and whatever, they need to not be taken with MAOI inhibitors. That's just an older kind of antidepressant. We don't see it a whole lot anymore. It's used to treat usually when people have failed at all of these other kind of medications. So yeah, stay away from those. If they've had a recent MI or heart failure, again, a suicidal ideation. So if I were you and I were studying for this test that is focused on diabetes and diabetic complications, I would not memorize more than it's used for, like it's supposed to be an antidepressant. This is an off-label. I'd memorize it has anticholinergic side effects and then a risk of suicidal ideation. Those are like the main things. I wouldn't worry about anything else. Oh, sorry. And also that it doesn't kick in right away. It takes 2 to 6 weeks, which is very, very common for antidepressants. Another thing that we would use for neuropathic pain would be an anticonvulsant. And so the two big ones, two main ones, gabapentin and pregabalin, or Neurontin and Lyrica. So GABA is this kind of neurotransmitter that inhibits certain brain activity. Of course, the exact mechanism is unknown. Actually kind of helps us because we don't have to memorize it. But, it's involved in some kind of modulation, inhibiting the transmission of noxious stimuli, which pain would be, and it may affect pain indirectly through the effect on mood and sleep. I mean, sure, you can kind of keep it in the back of your mind, but if you don't have it in the back of your mind going into a test, it's okay. There's more important things to ask. Adjunct treatment is a prophylaxis of partial seizures. It's an anticonvulsant. That's its purpose. So a lot of people are given it for seizure prophylaxis. And again, neuropathic pain is an off-label. Adverse effects would be, I mean, your main ones. There aren't a lot, to be honest. Maybe confusion, depression, short-term nausea. I've never seen anyone have any serious complications from taking one of these. And if you've been in clinical or been practicing, I think, you probably have some experience with these. They may have a drug allergy or hypersensitivity, could be angiogenic or anaphylactic, but again, it's something I've never seen either. Again, the only really important thing I would worry about here again is this increased suicidal risk. These are things we want to, and here's something that's, I mean, it's really important. Neuropathic pain has one of the highest suicide rates in terms of like medical causes, right? Like where people are just in so much pain or what have you that they consider suicide. Neuropathic pain is incredibly painful, and knowing that these medications can increase suicidal ideation is really important in a population where they are at higher risk than an average person for suicide. So it's a good thing to know. Other medications we might use, SSRIs, so selective serotonin reuptake inhibitors, similar to the tricyclics for this, in that they keep that serotonin in the system and hopefully will have an effect on the pain that way. It will also have the added effect of increasing serotonin for mental health issues, which is good. Opioids are used selectively, right? A lot of like the older tests will say, they might say morphine, or I had a test a while ago that said Demerol on it, and I'm like, we haven't used Demerol in like 15 years. So hydromorphone is really your big opioid that would be given for this kind of pain. Obviously, it's not something we want someone on long term, but sometimes there aren't really a lot of options. And then your capsaicin cream. It's made from chili peppers. You have to put it on 3 to 4 times daily. Use gloves. That's kind of something that I've seen show up on a test. But again, it showed up on a pharmacology specific test. What is important to know about capsaicin cream is that when you start using it, there is an increase in symptoms. And so it's very, very normal to have an increase in symptoms for a couple of days and then have pain relief a couple of weeks later. So if a patient asks, it's normal. This is something, if the patient's allergic to hot peppers because it is made out of chili peppers, we don't want to give it. Again, just think about what you wouldn't put chili peppers near your eyes or open broken skin. That would be very, very painful. And again, it's got that transient increase in pain and burning when you first start taking it, and that's normal. So we need to make sure to educate patients regarding that.